Good afternoon, everyone. I'm LaFontaine Oliver, President and CEO of New York Public Radio. And I want to start by thanking all of you for joining us today. A special thanks to Audrey Cooper, WNYC's Editor-in-Chief, Stephanie Clary, Deputy Editor, Sikan Akpan, WNYC's Health and Science Editor, and all of today's panelists who have taken time out of their very busy schedules to take part in today's important conversations. I also want to extend my deepest thanks to Dawn Weber, Vice President and Program Director at the Alfred P. Sloan Foundation, for your steadfast support of WNYC's health journalism and convenings. I'm as eager to hear from today's panelists as you all are, so I'll keep things brief up top and share just a few words. Some of you may have heard me say that local news and public media specifically is the oxygen of our democracy. That metaphor feels especially apt today in a room of health and science people who understand at a molecular level that the role of oxygen and breath and what it plays within the immune system, but who also understand how the health of the human body and the health of the body politic are also inextricably linked, and how both can be weakened by misinformation, disinformation, and political rancor. To me, independent, fact-based local news is the salve against these corrosive forces. It's what arms people with the information they need to make informed decisions for themselves and for their loved ones. And it's what brings us together across our many differences, transforming individuals into communities. So before I arrived here, I was at WYPR in Baltimore, and I was also serving my second term as chair of the NPR Board of Directors, a role I took on in November of 2020 after 4 years on their board of directors. So my sense of New York Public Radio was built on a pretty clear insight into this organization's leadership and impact within the public media system, and the unique way in which WNYC's locally rooted journalism has such profound national impact. That impact is, of course, on display with first-generation podcasts like Radiolab and On the Media, the community conversations of Brian Lair, who some of you know also holds a master's in public health, and of course, the continued excellence of the WNYC newsroom. But in March of 2020, what stood out most was the robust health reporting that the organization already had in place, which was fortified by the long-standing philanthropic support of foundations and major donors, which allowed our fearless teams to respond so rapidly and so effectively when the pandemic took hold of New York, and prepared them to mobilize new approaches, strategies, and toolkits that peer institutions could emulate as COVID quickly spread across the country. This organization was able to be in this position of leadership largely because of the support of Dawn Weber and the Sloan Foundation, as well as the Robert Wood Johnson Foundation, critical partners that have been both prescient and powerful in their longstanding work to make health and science journalism accessible to all. This annual convening we're all here for today, which Sloan and Dawn have supported for a decade, is evident of that. So on behalf of all of us at WNYC, I want to express my gratitude one more time to the Sloan Foundation and the Robert Wood Johnson Foundation for their partnership in supporting WNYC's health journalism. And now, let me pass things over to Dawn Weber, who will share a few more words. Thank you.
Thank you very much. It's a pleasure to be here, everybody. And LaFontaine, you mentioned 10 years. I was thinking back when Laura Walker came to me with this idea for a healthcare reporting unit. We were, back then, which seems like the prehistoric era now, we were concerned about the limited resources available for science journalism. And, there were shrinking jobs. And then, of course, the increasing complexity of healthcare. And specifically, that was the period of Obamacare. We were worried that it was good. We needed to help people navigate the complexities of the system. And in the last 10 years, as everyone knows, of course, we've had a pandemic. We are at this moment, for those of us in New York, are living under wildfire skies, and this healthcare reporting unit has become, I think, increasingly important for our culture, for our society. So we're very proud and pleased of the way it's developed and the great reporting it's done. I want to just mention a little background about what Sloan does. This is part of our public understanding of science technology efforts. We're like, think of us as a nonprofit multimedia company for science. We support books, radio, and podcasts, films, theater, television, and new media. So in addition to this wonderful WNYC healthcare reporting unit, we were founding sponsors of Radiolab. We support Planet Money and some other podcasts that are not connected to WNYC and PR that I want to mention are The Lost Women of Science, Gastropod, and How to Fix the Internet, which gives you a sense of the range of our interests. We also make book grants, about 20 books a year. We made a grant for an unknown author, Margot Lee Shedley, for book Hidden Figures. It became a Hollywood film, very successful and important film. And we made another grant for a book called American Prometheus, which won the Pulitzer Prize about 10 years ago, which will now be the subject of a new film by Christopher Nolan in July called Oppenheimer, which is about obviously the father of nuclear weapons and the Manhattan Project. And we also do a lot of television in terms of healthcare. We've had shows on how to survive a pandemic. We did an American Masters on Anthony Fauci and Extra Life with Stephen Johnson. And in the theater category this July in London, we have a play opening called Dr. Semmelweis with Mark Rylance, who co-wrote it and starring in it, which is about the pioneering physician who was thrown out of the medical profession for daring to suggest that doctors need to wash their hands. This was before germ theory, because they were inadvertently killing their patients when they were delivering children, because they were coming straight from the cadaver room and carrying germs on their hands. So there's a very broad array of projects that we support. And I could go on about that, but for now, you've got a really exciting series of panels coming up. So let me just thank you again for being here, and let me hand it to Audrey Cooper, the editor-in-chief.
Thank you, Doran. It's really, I wish we had seen each other in real life. This is another year of a remote pandemic and a remote health convening, unfortunately, because we're dealing with another public health emergency right now. I'm Audrey Cooper, the Senior Vice President of News and Editor-in-Chief of the WNYC Newsroom. And you don't have to look very hard today. You can just look out a window to see how important it is, things like this convening, and more importantly, the coverage that our health and science team does. It's really great to be able to discuss with you how our health team is really working towards making the New York City region a healthier place. And I just want to share a little bit of breaking news with you all as an example of this, just based on the audience numbers that we can track in real time. We know that New Yorkers and people who live in New Jersey are coming to us, especially this week, more than they ever have, to get real fact-based answers. Our audiences just in the last 24 hours have been up to 3 times bigger. And it just speaks to me to the need that this health team fulfills in this community and how important it is that it's here at WNYC. Since I've been here, and I joined WNYC 3 years ago, the health team has continued to just get better and better and do even more exceptional coverage. And it's really on 2 critical fronts: the crucial daily reporting that we rely on to just get through the day and inform our lives, and deep investigative reporting that holds the powerful to account. These investigations have repeatedly changed public policy and improved the lives of people who live in our region. And that includes our sustained work on lead paint exposure in city schools to more recently, this team's work in uncovering unsafe school ventilation measures during the pandemic. Recently, our coverage of the nurses' strike led to an exclusive report on a baby who tragically died in Mount Sinai's NICU unit, which calls into question the staffing decisions and preparations made by hospitals in advance of that strike. And there's even more to come. I can't share too much about what we're working on right now, but we have a really incredible story that you'll see soon, an investigative report on medical malpractice. These are just a few of the examples of this tremendous work that this team and others in our newsroom are doing. You know, COVID taught us a lot of things, but if there's one big lesson we learned within WNYC, within the community, and as the entire world community, it's that health and science are an inextricable part of the way we view our everyday lives. But in this new era when so many of us and the people that we serve have found ourselves in a position of trying to be or listening to armchair virologists and amateur climate wonks, and today amateur meteorologists, we at WNYC are in a really lucky position to have such a wealth of health and science reporting muscle throughout our teams. And of course, it goes without saying, but saying it is one of my favorite parts, that all of this is possible because of the support of folks like Sloan, the Robert Wood Johnson Foundation, and every one of our members, listeners, and readers who make this work possible. With that financial support and their fearless work to help us co-report our stories as they tell us their own, which is of course always, this is really what we're talking about when we talk about being a public media and having a public mission. And now I stop talking, and it's my pleasure to introduce my colleague, the editor of the Health and Science Desk, Dr. Sikan Akpan, a guy who knows the science and journalism, believe me, inside and out. Sikan, I'll give it over to you.
Thank you, Audrey, and many thanks to the Alfred P. Sloan Foundation and the Robert Wood Johnson Foundation for supporting another year of the Health Convening. So this year, we're looking at New York City's enduring crises. You know, the city is where people go. It's not only where people want to be, it's often where they need to be. The region has more health and economic resources to help and support just about anybody. So our panelists today look at three issues that will endure in some ways because they have to, but also because we need to find better solutions for addressing them. The 20-minute sessions plus Q&As will be moderated by the journalists on our health and science team, Caroline Lewis, Rosemary Misderi, and Jacqueline Jeffrey Walensky. The first panel will look into the roles that New York can still play in protecting abortion access. The second will look into the topic we all know well this week, particulate matter. You know, it and other forms of air pollution are ever present in urban areas, not only when there's a ton of wildfire smoke all over the place. So we'll dig into what that means for health disparities. And the third panel is going to look at how the city and surrounding areas can navigate the medical needs of asylum seekers as we find ways to welcome this new generation of Americans to our shores. And I just want to remind people that we'll be taking questions in the YouTube chat if you want to submit them. So let's get on to session one, Protecting Abortion Access in New York. It'll be moderated by Caroline Lewis, who is our premier healthcare reporter for WNYC and Gothamist. Along with abortion, she also covers cannabis, hunger, and pretty much everything else under the sun. And Caroline, I'll let you take it away and introduce your panel.
Awesome, thank you so much. So we are joined by Dr. Jillian Dean, who is the Chief Medical Officer for Planned Parenthood of Greater New York, and also Donna Lieberman, who's the Executive Director of the New York Civil Liberties Union. So I want to thank you both so much for joining me. It's a really, exciting panel, and I want to thank everyone who put the event on, and especially managed to make it virtual at the last minute. I think, in talking about abortion access in New York, until recently, I think a lot of people might have taken that for granted, and maybe some people still do. New York legalized abortion before it was even made a constitutional right through Roe v. Wade. The state has long been known as an abortion haven. But even before Roe was overturned last year, the NYCLU saw the need to strengthen abortion rights in New York with the Reproductive Health Act. So Donna, to start, can you talk about what that law did and why it was so important?
Sure. Abortion was legal in New York for many decades and before Roe, but it was legal as part of the criminal law, not part of the public health law where it belonged. And we thought it was really important to make abortion part of our normal and to normalize it as part of healthcare, because when running afoul of the law, it has criminal consequences. It intimidates people from doing what they think is right, because what if somebody thinks it's not? You have to undergo a criminal prosecution. So the Reproductive Health Act in 2019, and yes, at that point we were worried about losing Roe, and established that abortion is a fundamental right in New York. It protected minors' rights to get abortion, and it ensured that people could not be discriminated against for providing or getting abortions. This was a huge step forward, the most important thing that New York did since Roe v. Wade to protect abortion rights. We've done some other really important things since, but maybe we should hold that.
Yeah, I'm sure we'll get to a lot of that. For now, Jillian, can you talk about how things have changed at Planned Parenthood clinics since Roe fell? You know, are you seeing more people come in from out of state? Are you seeing people with like different needs or concerns than you were before?
Thank you for that question. When Roe fell, we looked at how we practiced abortion and realized that we did not need to change anything except to increase access, both for people coming from out of state as well as the New Yorkers who also depend upon us. So we expanded our abortion appointments. We increased our number of medication abortion appointments by 20% and also expanded our procedural abortion appointments. We are definitely seeing more patients from out of state. Now, New York being New York, we have always seen people from out of state. I've been providing care at Planned Parenthood of Greater New York back when it was just Planned Parenthood of New York City since 2007. And I have always seen people coming in during the college break to get an abortion, people coming in to visit a relative getting an abortion, because even before Roe fell, abortion might have been legal in other states, but it was not accessible. And so people have always turned to New York. And what we're seeing is people turning to New York, obviously, more and more and more. So yes, every day we're seeing patients who are flying in for abortions and flying out the same day, driving in, staying with relatives. Yes, changes.
And are you seeing people come in later in their pregnancies at all? You know, is that sort of an issue that you're addressing?
Yes, we are seeing that. Coming in from another state requires a lot of organization. You have to, first of all, raise the money to pay for that abortion, whether you raise it yourself or whether you seek help through many of the state abortion funds that provide the funding to cover the cost of abortion. So there's raising the funds for the abortion, there's raising funds for travel, there's organizing time off from work, childcare, transportation and lodging. All of these things tend to push a person later in their pregnancy. So we have seen and are prepared to see more and more people arriving later in their pregnancies, including into the later second trimester.
And so, you know, this is something that I think both of you guys have brought up, you know, when we were talking ahead of the panel is, you know, there's sort of a growing role for grassroots organizations and abortion funds. So I'm wondering if, you know, both of you can sort of, you know, whoever wants to go first can sort of talk about sort of the role that they play in continuing to ensure abortion access and sort of how we can best support them. Jillian, if you want to go first.
I can jump in to start. We rely on those other organizations to a great extent. It takes a village, and all of those aspects of just making it to the appointment that I talked about, there are organizations that help patients with that. Not only the state abortion funds, whether it's NIAF, the New York State Abortion Fund, or the ones that exist in other states, but there are organizations that help with transportation, covering the costs of that. There's organizations that help with lodging, where volunteers offer up rooms in their own home for people and their friends and family who are traveling seeking abortion to stay. And those same organizations often send people to the health center with the patient and help the patient escort the patient from the health center after their procedure. So these are key aspects to providing care, not only to people from out of state, but also to New Yorkers as well who need that help with those resources.
And Donna, are those groups facing more vulnerability now in this post-Roe environment?
Yeah, they're facing huge challenges because the need is so great. And they face unknown vulnerabilities because we know that the forced pregnancy states are determined to stop at nothing to go after anybody who gets, gives, or supports anybody to get an abortion. So I think that we haven't seen that wave of terror against abortion yet, and we hope we don't, but I think they have to be prepared, and we all have to be prepared to resist that. And I think that we should not assume, we can't assume that the abortion funds, the New York Abortion Access Fund or the Bridget Alliance, have all the resources they need. They certainly don't. The need is so great. And one of the things that we're trying to ensure is that New York passes the Reproductive Freedom and Equity Act that would provide a stream of funding for providers to provide uninsured people care, to provide and logistical support so that they can access the services that we have available here, and it would also strengthen the infrastructure of places like Planned Parenthood that need support, for their safety and security, et cetera.
Yeah, and I know that recently Governor Hochul has put state funds towards more security for abortion clinics. Jillian, is that something that you've seen a need for since Roe fell? Like, has there been more protests or more security threats?
There have certainly been more protests, and we were warned right after Roe fell that just like patients would be moving north and across states, so would the protesters be. And I don't know whether the protesters that I'm seeing outside come from New York State or from out of state, but I will tell you that the numbers have increased exponentially. We've also experienced clinic invasions where people have come in to our health centers and then caused significant disruptions because it turns out that they were not patients seeking healthcare, they were antis seeking to create chaos and distress our patients and staff. We have also had attacks on our, infrastructure, like the gates to our health centers. So I'm grateful that there is going to be more support for security. We certainly need it.
And Donna, are you currently fielding questions or concerns, about liability and things like that from abortion providers?
Oh yeah, we've always had a strong relationship with providers. And we've advocated for providers to be able to do their work and provide care for women. But the regularity of the meetings that we have with the Providers Roundtable has increased, and the questions that we're getting from providers: what can I do? What can I do? Because while in New York the law is pretty strong, it's not yet strong enough. People want to travel out of state. People want to provide telehealth to patients who may or may not live in New York State. And there are so many questions. What's happened as a result of Dobbs is not simply that 25 million women are living in states where they can't get abortion care. What's happening is chaos. The law is no longer clear. What you can and can't do is no longer clear because abortion is no longer a federally protected constitutional fundamental right. So the amount of questioning that we've had to address is significant. And honestly, there will be more and different stuff we try to anticipate, but these guys are creative in a not good way.
Are there any sort of
If I can add, I think chaos is one of their strategies. Sowing confusion and uncertainty among patients, among providers, and among the community. This chaos is a strategy. Even if they don't ultimately win on a particular legislative issue, they've sown enough doubt, created enough chaos that they have they've done significant damage and furthered their cause in that way.
Absolutely. And so, to that end, certainly, one thing that's pending right now is this case that originated in Texas, challenging FDA approval for mifepristone, which has been used for medication abortions for, 20 years. I think that came as a shock to some New Yorkers who might have thought we were immune to outside attacks on abortion access, since that's something that would affect the whole country. So I guess, Jillian, can you talk about how Planned Parenthood is preparing for the possibility of mifepristone being pulled from the market and what that would mean for patients?
Sure. Well, fortunately, right now, mifepristone is still available in New York State. And so I want to make it clear to listeners that abortion, including medication abortion, is legal and accessible in New York. And that includes the 2-drug regimen that includes mifepristone plus misoprostol. Now, if we were to ultimately lose access to mifepristone, Planned Parenthood of Greater New York, as well as healthcare providers across the state, would continue to provide medication abortion using misoprostol only. Medication abortion right now is provided with 2 medications. The mifepristone is the one that blocks progesterone and basically ends the pregnancy. The misoprostol is what causes the uterus to contract and the cervix to open, and the pregnancy is expelled, much like with a miscarriage. With that second drug alone, you can accomplish a medication abortion, but the effectiveness is lower. Thus, you need to use more medication. And that is the medication that tends to cause side effects, not just bleeding and cramping, but also nausea, low-grade fevers, vomiting, diarrhea. So we anticipate a longer course of symptoms when patients use misoprostol alone. And it's removing our, if we were to lose mifepristone, we would be losing our access to one of the most well-studied, highly effective, incredibly safe medications used in sexual and reproductive health care. We have decades of science showing that mifepristone is safe, is effective. It's been used by millions and millions of US women. And to take that out of our out of the reach of patients and providers with no basis in science would just be appalling.
Right. And IFI accounts for, I think, over 60% of abortions in the country.
Right. Just the volume of people who use it and get medication abortions right now is huge. And so I guess, Jillian, how do you feel as a doctor having to potentially change your protocol for patients based on this type of legal challenge, the decision of anti-abortion advocates and, judges as opposed to medical professionals?
Well, it wouldn't be the first time that as abortion providers, we are asked to tie ourselves in knots to comply with regulations made by politicians who don't understand basic health care. But that is exactly, that's what it is. It's frustrating. It makes us all very sad that we would be potentially required to provide the care that was not the highest potential level of care because of politics trumping science. How does it make me feel? Angry, sad, yeah. And mostly sad for my patients.
Yeah. I mean, it's one of those things where it seems like it's just a sort of marathon in terms of fighting to maintain the same level of access over time. And so
I will also say that really upset that we spent weeks preparing for the loss of mifepristone, time that we could have spent providing care, improving other services, enhancing other ways of serving the many people who are coming to see us every single day. And it diverted our attention to this issue that was, it was basically just it was a trumped up non-scientific attack on a foundational sexual and reproductive health medication. And again, it's that distraction, it's that chaos that gets in the way of us basically just providing essential healthcare services like we do every day.
So I'm going to ask another question, but I do want everyone watching online, if you're watching on YouTube, to put any questions you have, in so that we can take them. We're happy to take your questions. So, a last one from me, Donna, are there other legal strategies from abortion opponents that you guys are looking out for right now?
Well, I think we're concerned that there will be stepped up attacks on the right to travel, you know, on people who accompany or support young people to go out of state to get abortions. Yeah, but it's really whack-a-mole. But I think that I'd like to turn your question into other legal strategies that we have to protect abortion rights and in New York, and we have many. The most important is to, you know, we lobbied hard for a New York State ERA, Equal Rights Amendment, that would enshrine abortion in our state constitution and inoculate New Yorkers from any possible attacks on abortion rights. That's huge, and it'll be before the voters in the 2024 election. It's not absolute protection, but it's pretty ironclad. And we're also trying to beef up our privacy protections. Electronic health records are great, they're convenient, and they are dangerous for women who come from other states to get abortion care if their electronic data is being shipped out, sold, or whatever to forced pregnancy law enforcement officers. So we have to protect the data as much as humanly possible. We've done some, we need to do more, and we also need to protect, we need to enhance our shield law for providers so that New York is doing everything we possibly can to ensure that if you provide telemedicine in New York, you are not susceptible to any repercussions in New York for doing what's medically appropriate and legal and good for patients here in New York.
Yeah, absolutely. Actually, to that end, you know, Jillian, are you seeing patients who are really worried about giving their, you know, information when they come in for abortions now? Did she freeze maybe? I'm unsure. Well, she might be frozen and might need to come back online. I'm not seeing any questions yet, so I might just try to ask another question to start. So, you know, I guess as far as like what we've seen, oh, sorry. Oh, Jillian is back now.
Yeah.
Okay, great.
Sorry.
I was asking before, you know, have you seen patients coming in who are who are like showing concerns about giving their, you know, personal information when they're coming in for abortions?
Yes, when Roe initially fell, we thought, oh, we're going to track this.
Okay, well, let's see if we have any questions yet.
Yeah, I'm going to pop in real quick.
Okay,
just a question for both of you. You know, as we sort of report the situation, you know, in New York or even abroad, you know, what are some areas that you think journalists or policy makers or anyone should sort of be paying attention to going forward?
Well, I think that it's really important for the public to understand the impact on people of these abortion bans. You know, I know that there are apparently 5,000 or more fewer abortions in this country every month. That's like 60,000 a year. 60,000 women a year are being forced to carry to term, forced to have a baby when they're not ready to, when it's against their health. I mean, it's like mind-boggling to somebody in my generation that could happen in 2023. Those stories are important. I think the stories of the unintended consequences, even for the right wing, where people who have ectopic pregnancies, people who miscarry, people who have stillbirths, are forced to carry pregnancies that have no possibility to do anything but hurt them is really important. But the ordinary stories of like what it means to be able to control your reproductive life are really important for journalists to cover. And the one other thing I would say is, intersectionality. Okay, what does that mean? That the folks who are coming and the rationale for coming after abortion rights is really almost identical to the rationale for coming after so many of our other fundamental freedoms, like the rights of LGBTQ people, particularly trans kids and their parents, the right of parents to raise their kids and take care of the medical needs of their kids so that they are as healthy as can be. These attacks are of a piece. And I think it's important to cover that. And I think it's important to cover also the changed role, mission, and lack of integrity of the Supreme Court in all of this. Corruption and violations of civil rights. We all know in the civil rights community that corruption and police abuse go hand in hand. Well, we see here that corruption and a lack of respect for fundamental rights also seems to go hand in hand in a much broader context.
Jillian, do you want to add anything to that about what people should be covering when looking at these issues?
And I'm sorry, I don't know why my internet is unstable, except that it's an old building and we are full of people and patients. So I heard most of what Donna had to say. And I think that when the media tends to talk about the experience of abortion, there's often a tendency to focus on the extreme cases, the young incest survivor, the rape survivor, the person with the late diagnosis of fetal anomalies. But I think it's really important to tell the stories of all of the other people seeking abortions for the myriad other reasons that people do, whether it's for financial reasons, whether it's to finish their education because they already have children at home. In fact, most people who seek abortion are already parents. And whether it's because they just they're not ready to have a child now or ever. I think those are really important stories to delve into too. And I think whatever the media can do to encourage people to tell their own abortion stories so that it's more normalized would be a huge boon to the movement.
And then the flip side, oh, sorry.
You would also ask the question about people not sharing where they're from, and I don't know if you want to return to that, but you let me know. And you were asking something about a flip side. Oh,
well, I was going to bring up an audience question, but yeah, let's touch on that. You mentioned, I mean, this is something we discussed before, but are patients like hesitant to share personal information now? Like, do they seem more scared?
Yeah, so of course, like any other healthcare provider, we ask for your address when you come into the health center. And we noticed a lot of people giving the address 26 Bleecker Street. Well, that's the address of this building that I'm sitting in. And that's because they are not comfortable divulging their home address. Sometimes the address they give us is the Airbnb or the hotel where they're staying, or it's their sister's apartment in New York City. People are afraid to say where they are coming from because where they're coming from, what they are doing, what they're seeking from us is illegal. I mean, that's a crazy, crazy position for somebody to be in, that the care that basic healthcare service that they need is illegal in their state, and yet they can come into New York and it's a normal part of the healthcare offerings at our center. It's a very bizarre world. But what it does is it causes patients to feel like they're not sure whom they can trust. They don't want to face any repercussions back home, or have their loved ones who supported them in seeking the abortion seek any repercussions. So we respect their privacy. We've stopped trying to collect data about people's state of origin. So I won't be able to give you any actual stats about how many patients we're seeing from out of state, because we've decided to allow patients to tell us what they want to tell us about where they come from.
Thank you. Yeah, I mean, it's right. It makes it harder to sort of know the full picture of what we're seeing. And so there was an audience question. What is the most important thing a layperson can do to help support abortion rights in New York?
I'm going to be honest, I think a lot of it is money. And it's not just giving money to help, but I mean, sure, Planned Parenthood of Greater New York would love donations, but it's not just making donations to the healthcare providers, it's making donations to all of those other services that wrap around the patient that I was talking about, like Bridget Alliance that Donna mentioned that helps people with transportation, Haven that helps people with lodging, the New York Abortion Fund. So donations are a big deal. We also need a lot of escorts. We were just having a meeting this morning about how because of New York State regulations related to sedation provision, we need escorts to help patients who've received sedation leave the health center and return to wherever they're staying. We need more people to volunteer to do that kind of escorting if they have time during the day. There are organizations you can reach out to, like Haven, to Haven Coalition, to look into providing that kind of support. There is more need than there are volunteers right now to help patients safely navigate and easily navigate the system.
That's good to know. Yeah.
I would add to that that you know, the New York State Legislature is about to adjourn for the rest of the year, and they have some unfinished business on their plate to protect abortion rights. It's great that they passed the ERA last session, but there's a data protection bill that is before them, the Rosenthal and Kruger bill, that would build on privacy protections that we already have and prohibit the sale of confidential medical data out of state. There's the telehealth shield law that would protect telehealth providers explicitly from attacks from the outside and having any New York repercussions. And there's a hospital transparency bill, which would require hospitals to let the public know what services they provide and what services they don't, because we all know that there's a whole chain of Catholic hospitals that's ideologically driven and does not provide complete comprehensive reproductive health care. So those are three bills that need to be supported today. And there are and New Yorkers will also have an opportunity in the 2024 presidential election to vote on an equal rights amendment that would enshrine reproductive rights, gender equality for people from other countries, protections against discrimination based on disability and age into our state constitution. So equality for New York is very important for everybody in New York and for people who want to come here because they live in a forced pregnancy state.
Thank you guys so much. This has been a really informative and enlightening panel. And just thank you so much again for joining us. I'm going to turn it back over to CCON. Back to you.
Perfect.
Thank
Great.
you.
Yep. Thank you, Caroline, and thank you, Donna and Dr. Dean. We're going to pivot to our next panel, which is session 2, the lasting imbalance of car emissions. It'll be moderated by Rosemary Misderi, who is our Metro Science reporter. I like to think of her as our go-to person to address questions about climate change, physics, outer space, and motorcycles. So, Rosemary, if you're ready, I'll let you hop in and take it away.
Thank you, CCON. First, I wanted to start with air pollution is the leading cause of preventable deaths globally. Almost 9 people die prematurely every year because of outdoor air pollution. And if this week hasn't been proof of how it feels for a lot of New Yorkers on a regular basis with the regular amount of air pollution we have, now you know how those people feel. The heaviness on the chest, a lot of people already suffer from this. And of course, the biggest source of air pollution is the burning of fossil fuels. And before we start, I wanted to give you an idea of just how much air pollution is caused by a vehicle. So here's the scenario. You have a new 2023 vehicle, like a Ford Escort, a light duty vehicle, a 4-passenger vehicle, and it is up to the 2023 EPA emission standards, okay? And you're gonna drive it across the Brooklyn Bridge, which is about 1 mile. Now, the amount of carbon dioxide that is released by that car going across the Brooklyn Bridge when there is no traffic is 202 grams per mile driven. So 202 grams of carbon dioxide gas are released into the air driving across this bridge. And just to give you an idea of how much that is in weight, this is a box of Domino sugar. This is a glass beaker that is about 1 cup. Okay, so I'm gonna pour some in, and I measured this out earlier. So it is about this much. This is almost a cup of sugar that is released in carbon dioxide by a new 2023 car that is at EPA standards every time it goes 1 mile. So I just wanted to quantify that for everybody. And my go-to sources for air pollution are with us now. I call them all the time whenever I have any sort of question about air pollution, especially car emissions, which are one of the biggest forms of air pollutions. First, let me introduce Ilias Kavoris, who is the professor and chair of environmental, occupational, and geospatial health sciences at the City University of New York. And we're also joined by Marianthi Anna Kiumorjoglu. Did I get it right? Okay, who is an assistant professor of environmental health sciences at Columbia University's Mailman School of Public Health. Thank you both for joining me today. And the first thing I wanted to get an idea of, let's talk about first, like how bad is the pollution of car emissions? Like what are some examples of like daily hotspots you would see? And then we can talk about what are the hotspots in this city. Let's start with Ilias.
So yeah, thank you, Rosemary, and welcome everybody in this. Air pollution and traffic is something we are regularly exposed. We don't have the choice to say we are not gonna breathe here. We have to breathe. It comes to us. So areas where we're exposed to traffic is pretty much everywhere in our life, but it is when we are by the walking by the street or where there is a high concentration of traffic, either moving or idling, which is probably quite frequent in an urban environment. So whenever there is a traffic congestion, the cars stop on traffic lights, or in general, cars running without moving, then there is a concentration of exhaust that's not only carbon dioxide that you gave us a very illustrative example here, but there are other pollutants, including very small
We're going to get into
particles.
those soon. We're going to get into that whole big list. I just wanted people to be able to identify, like, let's look on the street and see what and translate what people are seeing. Like, so for example, the school bus, like to me, that's one of the biggest dangers, is because that doesn't even run on unleaded gas. That's diesel, which is a lot more pollution than a regular car vehicle. Yeah. And it sits in front of a school where there are children who are more susceptible to this air pollution. So are there any other examples, Marianthi?
of locations in the city specifically, or of specific cars?
Let's talk about specific locations in the city where there are hotspots of car emissions and idling.
So lower Manhattan, mid and lower Manhattan, and I know we're getting into that later as well, that has high concentrations. Near highways, South Bronx, the Brooklyn-Queens Expressway, and as Dr. Kamara said, everywhere where there are idling cars and buses, near roads where trucks are allowed to pass as well.
And before we get into the, well, actually, let's just go into this. So there's this huge long list of pollutants that come out of your car. It's not just carbon dioxide. Marianthi, why don't you take the first one on your on the list, on your list of emissions?
So first, I would like to say that carbon dioxide is extremely important for climate change. It's a greenhouse gas, but at the levels that it's emitted, it's not toxic to humans directly. It's of course toxic through climate change and everything that brings. But otherwise, that's not the main problem for direct inhalation from traffic, but it's the particles and some other gases that we know are very toxic. We know some of them are known carcinogens. They're combustion products. Most combustion products rather are very toxic when we inhale them, and they can then induce systemic reactions. So it's not only in the lungs, it doesn't stay only in the lungs. But what also comes out of traffic is those particles that can penetrate deep into the lung. Fine particles, ultra-fine particles. Ultra-fine particles are less than 100 nanometers. They're really tiny. They're not visible. Well, not these days. Usually they're not visible with the naked eye. You cannot see the particles. And as I said, several volatile organic compounds, polycyclic aromatic hydrocarbons. These are all lung irritants. These are all, not all of them, but some of them are carcinogens. Many of them are very toxic. Heavy metals from not only tailpipe emissions, but also brake wear and tire wear as well. That can be very toxic as well, because these are heavy metals and have been linked to multiple adverse health outcomes.
Since you mentioned fine particulate matter, which is one of the most dangerous ones on the list, Ilias, can you take us through an explanation of why this is dangerous and how fine particulate matter affects the body from the moment it's in the air and you inhale it to all the possible things it could do to you?
Yeah, thank you. Marianthi already alluded to that on why particles are important. So particles come in different shapes and sizes and compositions, but the most dangerous are, the smaller the size, the most dangerous they are. And the fine particles and ultrafine, the even smaller ones, less than 100 nanometers, are the one that once when inhaling, it goes through tens and ways, and particles will deposit in different parts of respiratory system. The smaller they are, the deeper they go. So, and they settle on the lungs, and the lungs are very sensitive to organs. So they don't like to be in contact with foreign objects, and particles are them. So the smaller particles will go into the alveolar region, and where there is exchange with the blood, and then they can translocate into the blood, and then it's open game. They can go throughout the body and affect other organs. The liver, the pancreas, the brain, the cardiovascular system, the heart, it's everywhere. So, and as again, Marianthi alluded before, it's not just particles, it's not like sugar in it or so. They contain chemical species that are very hazardous, carcinogenic, mutagenic, toxic to humans at different organs. So heavy metals is another group, polyaromatic hydrocarbons. The list is endless. It's limited by what we can measure at this point. And we only know 10 to 15%, and that's not very good. You can imagine what else is there that we don't have the technology to do it, but we're getting there. We're learning what their impacts are, and we're trying to understand what these chemicals are. Another group, another set of compounds is the gases that has been mentioned before. Some of them again toxic. Benzene, we heard about benzene is not a good, but many nitrogen oxides. Now both VOCs and nitrogen oxides are involved to create another type of pollution. That's the ozone pollution, which we actually had one in April alert very early in the season, which we're about to have a lot of them this summer. And it's gonna be one of the aftermath of the smoke we're experiencing right now. So traffic is it's there in different ways and it lasts for long. Plus traffic is always present in an urban environment. At lower concentrations probably than the one we experience today because wildfire is massive in scale, but we're exposed to traffic 365 days a year, every single year of our life. So
Marianthi, thank you, Elias. Marianthi, can you put names, conventional names on some of these conditions that these outcomes that or diseases that end up becoming chronic and a lot of the other negative outcomes that are suffered by New Yorkers as a result of breathing in all this car exhaust?
Yes, absolutely. And I will just add to what Elias just said, that was very comprehensive and great, that those ultrafine particles that he mentioned, they can not only go through the bloodstream, through the lungs, but they can even directly pass to the brain through the olfactory bulb. So there's a direct link between what we breathe and the brain. So they can be very toxic to the brain as well. So talking about outcomes, we know that traffic-related air pollution, specifically traffic, not general air pollution, because traffic tends to generate a particularly toxic mixture of air pollution. And so it has been linked to respiratory outcomes, of course, asthma, COPD. And we see that many of these outcomes, I should say, we see both exacerbations with short-term exposures. So high traffic pollution today, high rates of asthma admissions today, but also long-term exposures can lead to chronic outcomes and onset of outcomes. So for respiratory, for example, I said asthma, COPD, cardiovascular impacts, heart attacks, strokes, neurological outcomes. We see that these have been associated with aggravation in Alzheimer's and Parkinson's, and even amyotrophic lateral sclerosis, pregnancy-related outcomes, preterm births, miscarriages, lost pregnancies, mood disorders. The list is really, really very long, because as Elias said, the way that air pollution impacts the body, and specifically a very toxic part of air pollution that is traffic, is systemic. So air pollution induces systemic oxidative stress, systemic inflammation. So any system and organ in the body that can be affected by inflammation and oxidative stress can potentially be affected by air pollution.
And what is the relationship between this air pollution and also childhood asthma?
It's a very consistent, clear link that we see in our studies.
And to be clear, these childhood asthma cases, some of them it's asthma being developed in children that would not have gotten asthma to begin with, because certainly there are children who are born with asthma or develop asthma over the course of, but this causes asthma in children that didn't even.
So it's two things. It definitely, for sure, exacerbates asthma symptoms. So among children who have asthma, makes things worse. But also, yes, there have been studies that have shown that air pollution, elevated air pollution levels, are associated with onset of asthma, with asthma incidents.
And I also, just before we go to the next question, I just wanted to remind the audience, if you have any questions, just drop them in the chat. We'll take them on during the Q&A. And also, I'll ask this question of Elias. You meant we talked about like the wildfires that are going on, and how I just wanted to get an understanding of we have our regular air pollution, which is already terrible. How much is this this added air pollution from the wildfires? How much of an impact is it creating, like on top of all this?
A lot. We experienced it the last 3 or 4 days, and as Marianne mentioned, it just doesn't affect the way we breathe. It affects us as an individuals, from the mood, for the way we are behaving, the way we're moving, the way we are breathing. So this is the pollution we experienced the last 2 days, today and probably a couple of more days, is an order or 10 or 5 to 10 times more, even if not more, than what we will experience a regular day. And this is not something we're very familiar with in Eastern United States or in New York City. So, but it may be something we may get to be familiar, because wildfires are related to changing climate, and we're going to be having more and more of these in our neighborhood, in our area. So that is, the wildfire, the smoke is going to go away as the weather patterns move away. So, but this shouldn't forget us. We shouldn't forget what it felt like, because cumulatively we experience the same thing from traffic over a year. It's just small quantities. Here it's a lot of quantity over 3 days. There is small quantity, small pieces over the lifetime. But also we're going to have some more of these events in the future.
I wanted to get an understanding there. I've read a lot recently that said the air quality of New York City is the worst, one of the worst in the world right now. And I want to get an understanding of, like, so it's been like this for, like, we're on day 3 of this. How many days of exposure does it start to become problematic to this level of air pollution? I know I'm throwing you a curveball on this, but
Which one of us do you want to answer?
Oh, sorry, Marianthi.
I think even some hours are bad, right? So I think we see for normal air pollution, not our normal, because we should say this is the normal in certain parts of the world. The fact that we don't experience this daily is just, that means that we are fortunate, but there are millions of people, probably billions, that live with these levels every day. But we've seen in the normal levels that we're experiencing that for certain outcomes like cardiovascular disease, for example, 1 or 2 days of elevated exposure can result in impacts, in adverse impacts. There are certain outcomes that's even just a few hours. So 3 days is already a lot. And especially.
And before we move into the Q&A, which is we should start now, I just wanted to take a moment and talk about, like, well, how can we lower our emissions? Like, some solutions like individuals can take to lower their emissions. Let's start with Ilias, and then Marianthi will go to you next.
First of all is try to reduce emissions from traffic. I know this is a big thing, but what we can do is don't drive as frequent as we do. Use public transportation. Use other means. Bike is a healthy activity as well. So, and if you need to drive, all of us need to drive. So then manage your trips so you don't do a lot of small trips, but just coordinate so you reduce your emissions. And then take care of your car, so that you mentioned the example, a new car, but not everybody is new. Take care of the car, and so you reduce your emissions. And then on the community or the city level or the institutional level is start changing the characteristics of the fleet. You mentioned the diesel buses, why we cannot transition to cleaner buses, electric buses as well. That's going to be good for the younger generation too, and engaging with them. So, and reroute traffic, sometimes it helps. Congestion is caused by putting a lot of people, a lot of different heavy-duty trucks and passengers on the street at the same time. Manage the traffic in a clever and productive way. So there are ways that can be done on individual level and the institutional level.
Marianthi, anything to add?
Yeah, yes, I would say I absolutely agree with everything that Elias said. But as he also said in the beginning, traffic-related air pollution is such a ubiquitous exposure. We cannot avoid it. So yes, there are things we can do at the individual level, but ultimately, not many people have the option to change where they live or to get a cleaner car. Or even if I get a cleaner car, can all my neighbors also get cleaner cars, right? So ultimately, I think this needs to be a federal, state, city effort to make sure that our cities are healthier for us. So provide alternatives other than us taking the car, make transit easier, mass transit, more bike lanes that are safe, promote these types of transit over car and make it easier for people and make sure that these, yes, downtown Manhattan is very well connected with buses and subways and many bike lanes, but that's not the case for everywhere in New York. So, and I know the city, New York, is making many efforts towards that, but we just need more, I think.
Thank you. I don't see any audience questions yet, so I am going to drop a big question bomb, which is congestion pricing I'll start with Elias. Is congestion pricing a solution for this?
Congestion pricing is a traffic management tool which gonna help redirect the traffic. And it's implemented, it's gonna be implemented in a certain way in New York City. So the outcomes are still debated in terms of the air pollution, because New York City is not just the component where the zone will be implemented. In New York, as Marianthi mentioned, is well interconnected. So if we make a small change here, how it's gonna impact the rest of the city? And we know there are hotspots of pollution and adverse outcomes around the city outside of the lower Manhattan. Already mentioned South Bronx, East Harlem, Flatbush in Brooklyn. So how controlling one thing here, how it's going to affect the rest of the city, that's a question to be answered, unfortunately. And because the last thing we want to do is solve a problem here and worsen an already bad problem in other communities. Particularly those with a strong, unfortunately, social and health disparities around New York City. So it's definitely a valid traffic management policy. We need to understand better how it's going to affect the New York City ecosystem, which is more complex than just Lower Manhattan.
Marianthi, you have anything that you wanted to add?
No, absolutely agree. And in theory, at a theoretical level, what we've seen from European cities, which may not necessarily translate to New York, but such measures do tend to reduce more in the congestion zone, but overall reduce levels of air pollution throughout the city. However, as Elias just said, there are many neighborhoods in New York City that are already more vulnerable to air pollution effects. So it's not the same, even if congestion in the zone does not end up increasing air pollution in those places, which is debatable, as Elias says, we don't know. Some predictions show that air pollution will increase in certain neighborhoods outside the zone. But even if overall they will decrease, they will not decrease at the same level. Obviously, there will see major reductions within the congestion zone, lesser reductions elsewhere. And this is also an equity issue. So I think what's very important, I do think congestion pricing is a good idea, but it needs to be implemented with complementary policies that ensure equitable reductions throughout the city.
And I also wanted to ask, this is also for our listeners and the people who are who are listening into this panel, who are not living in New York City, because we have a large sprawling area of suburbs surrounding the metro area. Is car emissions and idling, is that just an urban problem, or is this problem also part of the suburbs that surround New York City? Sorry, Elias.
Oh, the beauty or the evil with air pollution is it doesn't recognize communities, boundaries, areas. And it moves around, as we've seen with smoke. So it's not an urban area problem. It's not a downtown problem. It's a problem that affects different communities differently. So as we mentioned, pollution evolves. What is coming out of the cars is not necessarily the same that's going to be 10 miles down the road, but equally harmful, if not more harmful. So everybody should be aware and concerned when there is emissions from traffic. There is component. Those in urban, those in suburban communities around the city. That's where the ozone problem, for example, exists, not in downtown. Although it is caused by what's emitted by traffic in congested areas. So it is a problem that affects counties, cities, in our case, the tri-state region altogether. And it's not a single source that's causing, it's all the traffic in this parcel or this area that is coming together to create the problem.
Marianthi, can you tell us, can tell us how, in a suburban scenario, the emissions might play out differently? And also, Elias reminded me, please, if you could talk a little bit about ozone, also as part of this pollution, because I was meaning to mention that. Thank you.
Absolutely. So when the buildings are not so dense and when you're downtown Manhattan, buildings are pretty high, right? So that traps the traffic related air pollution in a way as well, because there's not enough space for it to be diluted. So when you're out in the suburbs where also there are more trees, this is not as much of a problem, even if you had the same congestion in theory. Of course, it is a problem, especially because you do need highways to reach those suburbs. So you may think, and you don't see air pollution, again, with the exception of these days, you usually don't see it, don't smell it. But if you are in a suburb next to a highway, you are exposed to it. But going back to ozone is not, for the most part, not directly emitted in the atmosphere, but it has a very nonlinear chemistry that includes emissions from cars. We get these emissions from cars and occasionally some emissions from biogenic emissions from trees. And these need to stay in the atmosphere in the presence of sunlight for the chemical reactions to occur to generate ozone. So ozone, we don't see ozone where traffic-related air pollution is very high, but we see ozone concentrations pick up as we move away from that. And that's usually the suburbs. So we may end up having, if you see maps of the city of NOx, for example, that's associated with traffic emissions, but even fine particles, and then ozone, the colors are kind of flipped. So where you have a lot of NOx and traffic-related air pollution, you don't have much ozone, but you have a lot of ozone downwind from that.
And Rosie, I'm just gonna step in because we're running a little bit short on time. We have one more question from the audience, and I thought maybe I would pose it to all of you, including Rosie. Do you feel like that there's enough interest from city officials and state officials to make this transition to cleaner energy, to fund it, especially for public transit, and maybe even just other transportation infrastructure. Rosie, you've covered a lot about chargers for electric cars. And then Rosie, you can go ahead and close out the panel.
I mean, I know that the MTA has plans. For example, the buses, they're supposed to go fully electric. I think it's in 10 to 15 years. It's supposed to they're supposed to go completely electric. And a lot of their lines, like I live along the M86 line, which is completely electric now. And so I see that there are plans in place and procurement plans in place for the MTA to transition to cleaner sources of energy. But I don't know if it'll come in time, because these kinds of plans and transitions, especially for the MTA, which transports millions of people every day, is going to take a long time. And I'm going to pass the question off to Marianthi to take over.
Thank you. I think we are very all lucky to live in this city, because relative to most other US cities, American cities, actually New York is at the forefront of setting these policies, of trying to clean up the fleets. We had the clean bus initiative, the clean taxi initiative, residual heating oil. I know we're talking about traffic, but we've had all these initiatives that we've shown with our studies have resulted in significant reductions in air pollution. So there are already many steps being taken, but we do need more. So yeah, there's always more to be done.
Yeah.
Elias, do you want to add something?
I agree with Marianthi. He says, I think there is a political will to do some, but it needs to be sustained. We don't live in a problem that will be solved in 1 week, in 1 month, in 1 year, or over in one election, 4-year period. That's usually the time span for politicians. This is gonna take many years, maybe a generation, to solve it and change the habits, because we are used to drive everywhere, to use cars. So it needs to be sustained. And I hope that on the city, state, and hopefully on the federal level, we'll keep that momentum keep going. Because again, it's not just New York City or New York State doing its own part, everybody else has to do their own part as well.
Thank you, Marianthi. Thank you, Elias. Please keep taking my calls. Thank you.
Bye-bye.
All right, so we have our third and final session of the day, which I've lost among a sea of tabs. Apologies. All right, here we go. It'll be moderated by Jacqueline Jeffrey Walensky. Jacqueline writes data and health science stories for WNYC Gothamist, whether it's the air quality tracker that she whipped up yesterday, or data sets about dog poop on New York City sidewalks. She's got it covered. And her panel is going to look into a topic that she's covered this year, the health needs of asylum seekers. So Jacqueline, take it away.
Thank you, Sikan, and thanks so much everyone for coming and for sticking around. Let me turn off the air purifier just for a minute so you can hear me talk. So I just wanted to give a couple of quick facts about migrants in New York City before introducing our speakers. First, pretty typically, we'll start with some data. So as of early June, New York has received more than 74,000 migrants, and about 47,000 are still in the city's care. That's overwhelmingly families with children. And it's very hard to make generalizations about the migrants in New York City, because everyone is unique and every story is unique. But one thing they do have in common is that many have faced great hardship, whether it's in their home countries, on their journeys, or since arriving in the United States, or all three. And because of that, they may have some special medical needs just as a result of their journey, let alone, any special health risks that come with staying in a congregate shelter, for example, or eating different food. And so I'm really pleased to introduce two wonderful experts who bring to bear like a wealth of experience and knowledge around migrants, refugees, and asylum seekers. They are Desiree Joy Frias, an Afro-Latina community organizer with South Bronx Mutual Aid and a South Bronx native. She also has both a JD and a public health degree, which is very cool. And also with us today, we have Dr. Greene Kaur, who is a physician, a medical anthropologist, and a human rights researcher at Weill Cornell Medicine in New York City. She's also the founding director of the Human Rights Impact Lab and a co-medical director of the Weill Cornell Center for Human Rights. So welcome to you both. I'm so happy to have you here. I was thinking maybe we'd start with Greene. Maybe, so based on your research and your clinical experience, can you talk a bit about some of those unique health needs of migrants, asylum seekers, refugees, and so on?
Thanks so much for having me, and thanks for that question. So we have to remember that asylum seekers are a very small percentage of the world's forcibly displaced population on the scale of about 2%. So these are the people that had the financial stability, the social networks, the other resources that it takes to cross multiple international boundaries. So this population tends to be young and healthy otherwise. I mean, think about how taxing an international journey can be, and what it would require to do that on foot with children, with very few resources. So it tends to be a very young and healthy population, but at the same time, they're incredibly vulnerable. They've experienced war or violence or persecution or a natural disaster. They are often traveling with young children, and the medical expertise that's required to provide them care is special, just like you'd want a cardiologist to treat heart disease or a pediatrician to treat a child. You'd want someone who's familiar with all of those biopsychosocial forces that can influence the health of this population. So for example, how does being displaced for months at a time affect kidney disease? Or how does it worsen heart disease? How does the stress of that displacement affect illness? And so you really want somebody who is specialized in treating those specific health needs of this population.
Great, thank you. And I'm wondering, Desiree, in your experiences working directly with some of the newest New Yorkers and talking to them and seeing their living conditions in shelters and so on, how are you seeing those special health needs manifest? What are the chief health needs that you're seeing?
Yeah, people come here to New York City from all over, but mostly through the southern border. And what we are seeing is people at the end of a journey that is arduous, no matter how short or long it was. And they are overwhelmingly young, but I am seeing a lot of chronic illness that isn't being maintained properly, as well as some people coming with pre-existing conditions that just were simply untreatable in their country for socioeconomic or any other kinds of conditions. So I'm really seeing some really serious health needs and acute health needs, but things that overwhelmingly are treatable or preventable. So I think that's really important to center as well, that the city really needs to anticipate not only triaging their health needs right now, but anticipating ongoing needs. And that if that's going to include chronic health conditions, then we need to prioritize preventative care now.
And what I hear you saying, Desiree, is that a lot of this is a lot of the health needs that you're seeing are the result in part of a disruption, the disruption of migration, or maybe the disruption that prompted the migration. And it reminds me of something that you and I talked about, Ganesha, about how medical records can often get lost in the shuffle. Earlier this year, we saw issues at asylum seeker vaccine clinics that did stem in part from staff not having the expertise to kind of interpret these international vaccine records. So I'm wondering, Ganesha, if you can talk a bit about that particular challenge for getting migrants up to speed on healthcare.
It's a great question. I mean, I think medical records in the best case scenario are challenging. It's challenging for me to look at somebody's medical record if they came from another state, another country. In the best case scenario, maintaining those records is hard. Think about, for each of us, how hard it's been to manage our COVID vaccination cards. when you go to a place and you don't have it, that gives you just a tiny little insight in how hard it is to manage those records. Now imagine you're leaving your country in an instant because a war broke out, or you have to cross an international boundary and you have to decide what to take with you. You might not have an opportunity to take your health records. You might not have the ability to take your health records. You may have to prioritize something else over those records. So there's that individual sort of ownership of the records. There's the difficulty in maintaining records from a health provider standpoint. And I think that is very challenging. When we see somebody with a chronic condition, it's so important to know how that's been managed by their provider beforehand. And without that knowledge, it's really hard to provide the best continuity of care, right? We can't provide the care as we would want to. You have that disruption in care, which does have health effects.
Yeah, absolutely. Like it's hard to pick up where another provider left off if you don't know where the provider left off, right? Mm-hmm. And I'm sure there's also all kinds of complications and nuances when it comes to, formulations and standards of care from different countries as well. I wanted to shift just a little bit because I feel like we've talked a bit about sort of the health challenges that maybe folks are bringing to the table or picking up along the way as they travel. But one thing that we've learned from reading about these shelters is that living situations and food themselves can pose a risk to human health, in addition to everything else. So I'm wondering, Desiree, if you can talk a little bit about what you're hearing and seeing about the conditions of the shelters and the food, and how might that impact people's health?
Yeah, so the conditions of shelters for all unhoused New Yorkers is unacceptable by my standards, and I think by most public health standards. We really are seeing a lot of transmittable diseases, things that are totally preventable, but just because of chronic underfunding, and not even underfunding, but actually, contractors taking money and misspending it. We're seeing expired food. We're seeing meals that are not culturally appropriate, but are nutritionally deficient. A lot of migrants are reporting GI issues. I'm not a doctor, but things like, that they're vomiting and they're having diarrhea, and they tie it to the food. They say, when I eat this food that's being served at the shelter, these are the physical reactions that I have. And I think that an issue that's going on, especially in the housing side, is that for some reason, these migrants, we have this number of 70,000, but there's no central database of where they've been, who has spoken to them. And a lot of times as mutual aid organizers, it feels like we're the first person to speak to them. I'm speaking to people at 30th Street Men's Shelter outside when I do distros, or at the Path Family Intake Shelter. And we're seeing people with really basic and very serious things like diabetes who haven't had, one man told me he didn't have insulin since Colombia. So, they're going in and out of these shelters, but for some reason, their paperwork isn't being tracked, their cases aren't being tracked. And some people are starting from scratch over and over as the shelters close, as they're moved from the tent cities that we saw at Orchard Beach and Randall's Island into the shelter system. It seems like their cases are not following them always.
So what I'm hearing you say is, like, it's not just the displacement and the disconnection of leaving your home country. It's also having to move, multiple times, like within the shelter system.
Absolutely. And even with the Port Authority Welcome Center, that was just closed on May 18th by Mayor Adams. And so now there are migrants arriving to that. Sorry, we got disconnected for a second. There's migrants arriving to that center that are being basically not knowing where to go next, because there is no welcome center there. The National Guard no longer has a presence there. And yet they are being sent here, kidnapped by governors to these, on buses to Port Authority, and they don't know where to turn.
Absolutely. And I feel like we're seeing that sort of lack of guidance manifest in other health effects as well. I know some things that, I've talked about, Desiree, are like chickenpox outbreaks and even issues with safe sleep. Can you talk a little bit about sort of like the sleeping arrangements or other ways in which the shelters might not be a very healthful environment?
Yeah, so, like I mentioned, people were being housed first in tent cities at Orchard Beach and Randall's Island. Some of the men were just moved into Lincoln Correctional Facility, which is a jail on the Upper West Side. We, of course, all heard about the Red Hook cruise terminal, where people were cold, and despite Mayor Adams sleeping alongside them for a single night, he did wake up and ask for a blanket. So the conditions are just not they're inhumane, and they are a direct impact on public health because people are not receiving health care. It's exacerbating these health conditions. And it's really just unacceptable conditions for anyone. And just because they are migrants shouldn't be classed them as a second group of citizens in our country.
Absolutely. I have a follow-up question that I want to ask about, speaking of exacerbating health conditions. First, though, it is time for my regularly scheduled reminder that if you have questions, you can send them via the YouTube chat, and we'll be really excited to answer them. I wanted to ask Ganesha a question. Speaking of all the health conditions that could be exacerbated by this journey, by these living conditions, I know that migration can lead to physical trauma, but also to mental and emotional trauma. So can you talk a bit about sort of the mental and emotional toll that these migrants have experienced?
Absolutely. I think when we can't necessarily, maybe we can in certain situations, but we can't necessarily change the war or violence or persecution or natural disaster that caused people to come to the United States. But once they're here, we can change what that health trajectory looks like, both in physical and in mental health. I think it's really easy if we imagine, and I think the current climate in New York City has made us do that, right? Imagine being outdoors, not being able to go inside and turn on an air purifier. I mean, that is the situation for thousands of people. Imagine not being able to access healthcare or being forced to sleep in the cold, not having access to food that makes you feel okay. I mean, there's really good science on how gut health affects your mental health. So all of us can understand what that would do to our mental health. How would that affect your mental health to be sleeping in the cold, eating food that doesn't make you feel good, that makes you feel sick? What would that do to your mental health? And we do see that. We see that in our patients who are coming in and who are saying, I can handle what happened to me in my home country. I can handle that, what I went through, the trauma that I went through, but this is really hard. I'm supposed to be in a place that believes in freedom. I'm supposed to be in a place that believes in the rights of immigrants, and I'm not feeling it. I mean, I had somebody say to me last week that I feel like I'm in the US, and I am free. I do feel free. This was somebody who was persecuted for being gay in his home country. And he said, I do feel free as a gay man in New York City, but I also feel like I'm in a prison. He said, I feel like I'm in jail because I'm fearful of going out. I'm fearful of those punitive immigration policies. I'm fearful that I'm going to be deported. I'm fearful of going outside and getting sick. And so I just stay home and I feel like I'm in a prison. Now, that's the situation for an adult. Now imagine what it feels like as a parent, not being able to care for your child and how much mental weight that carries. I think that is a lot. I think it can be completely overwhelming.
It's so interesting that you mentioned that fear of deportation, both the toll that it takes on mental health, and also one of the things that I think I've discussed with both of you is that it can also impact people's physical health in the sense that it can prevent people from seeking healthcare. I'd love to hear both of your perspectives on this. Maybe do we want to start with Desiree?
Yeah, I mean, right now what people are seeing is a 3-year wait for asylum cases. Work permits in New York City is well over 2 years, plus you have to have about $250 to $500 US minimum to be able to pick it up. And for many people, New York City is the end of their journey. And all of their money is gone because they have spent it on the trip here every single time. And, it's just not feasible for them to fund their immigration case, fund their work permit, fund a place to live in New York City. A single room is $800 minimum right now. And it's just the amount of pressure on migrants, on unhoused people in New York City is just immense, and the city is not relieving it through their policies. Another issue, Jacqueline, like you mentioned, was the chilling effect of laws in other states. So, migrants especially are using WhatsApp to communicate and have these giant group chats. They'll share articles and they'll understand that, Florida's another state, it's not the same law, but they kind of are really concerned about the federal climate and whether it's going to come down, and maybe New York will also have this kind of law like SB 1718, which is the immigration bill that has a clause that requires hospitals to ask their patients about their immigration status. So this is a really big issue across the country, and I think that migrants are feeling it everywhere, and they're scared to seek medical care. They have distrust of doctors for whatever reason, and it really becomes a really big barrier to care.
Yeah, I would piggyback off of that. I mean, I think there's really good medical literature about how stress has very real physical effects. I mean, multiple studies in general populations that show that stress can worsen chronic pain. It can itself is a risk factor for cardiac morbidity and mortality, for heart attacks, for strokes, for heart failure. So there's sort of the real documented physical effects of stress, and the stress of deportation, or like you mentioned, Desiree, the chilling effects of not knowing what might happen. I think there's what we've documented in our research at our lab is that there's 3 major barriers to accessing care for physical and mental health. There's trust barriers, structural barriers, and then knowledge barriers. So in terms of trust, remember that the experiences of refugees and asylum seekers with institutions is not always positive. On their migration journeys, they may have been placed in immigration detention or separated from their families. They may have experienced trauma at the hands of nurses and doctors, or with the assistance of nurses and doctors. So their experiences with healthcare providers and systems is not always positive, and there may be major trust barriers there. Displaced populations also don't have the same resources that you or I have. Their travel to hospital settings may take hours. They may have language limitations or barriers. They might find hospitals really complicated to navigate. I think a lot of us do. So imagine that in a different language, in a different setting. So those are sort of the structural barriers to accessing care. And then finally, there's knowledge barriers, both from the patient side, but also from the provider side. I mean, medicine is so much based on your personal experience. How many cases of a particular condition have you diagnosed and treated? And so if providers have very little experience with refugees, they may entirely miss diagnoses that could really affect the health of these individuals. And then from the patient side, they may just have no idea what they can access in terms of healthcare. We had a patient whose pregnant wife had tested positive for sickle cell disease, and he didn't want to get tested, even though that would potentially have an effect on the baby, because he didn't think he was allowed to. He was so fearful of getting deported. So that can have a major effect, that barrier of knowledge, and the structural barriers and the trust barriers in terms of accessing healthcare for mental and physical health.
That's such a striking story. And when you said resources, my mind, of course, immediately went to money as well, because I know that plays a big role here as well. So I'm wondering, maybe Desiree, since we've talked about this before, I have a report here from the city's independent budget office. They sort of estimated the cost of asylum seeker healthcare at about $1,500 per person for basic medical care, so not including any specialized healthcare needs. And I'm wondering, Desiree, if you can talk a bit about the importance of investing in healthcare, particularly in these, community health centers where many migrants are being seen.
Absolutely. Well, that's the question that honestly I get the most in mutual aid organizing is, who's going to pay for it? And I think the biggest issue is that we all pay for it. It's clear that we all breathe the same air based on the climate crisis outside. And, health is not individual. It never will be, especially if you live in New York City with 8 million other people. And I think capitalism also fails us in our healthcare system by ingraining in us that we have to earn a right to be healthy. That migrants, until they work, and they sure do work, migrants contributed more than $330.7 billion in federal income taxes in 2019. So $1,500, that sounds great. I'd be more than happy to start the GoFundMe, but I think that Mayor Adams has a more than capable budget to fund the healthcare needs, to provide safe staffing and nursing ratios in our hospitals and our public healthcare systems, to ensure basic vaccinations for everyone in New York State, and just ensuring that the public health of New Yorkers as a whole is maintained because it's their human right, not for any other reason.
Absolutely. I think, Sikan, am I supposed to bounce to you?
Hey, sorry. I was just typing some directions, but I can just say them. I can just say them. Yeah, so we have a couple of questions from the audience. Jacqueline, I'll ask the first one, then I'll let you ask the second one, and then you can close it out and toss it back to me. So the question is, hi, New York City primary care provider here. I assume the large majority of the migrants are unfortunately not eligible for New York State Medicaid, given their tenuous documentation status. Are most of the migrants being directed to Health and Hospitals primary care clinics? And thanks for this session.
I'm happy to have either of you or both of you. The only thing I'll say, I'm not an expert when it comes to insurance coverage. I do know that a few thousand migrants have been signed up for some form of coverage through NYC Care. I don't know how extensive that is. And the sort of community health clinics are doing the brunt of these visits. There are also on-site medical clinics at the larger shelters, like at the Row, the Stewart, and so on. And they do kind of like urgent care level care and will refer out for anything more complex. But if either of you would like to comment on sort of the health insurance side of things, I think that would be great.
Well, in our mutual aid work, what we tell people right now is that New York City Health and Hospitals are completely free to all New Yorkers, regardless of migrant status. And so those are the hospitals where on Google Maps it says NYC Health and Hospitals in front, like Metropolitan in Harlem. But overall, I think that New York City should really be encouraging everyone to get healthcare, signed up for healthcare through NYC Care, so that we can continue to lean on our public hospitals and kind of divest from this private model.
I agree. I think that's what we're seeing with a lot of our patients. I'm also not an expert in insurance, but a lot of our patients are going to clinics rather than big hospitals because I think it feels a little bit safer. It feels a little bit more familiar and less overwhelming. Just to something that Desiree said earlier, that $1,500 is a reasonable price to pay, and that sort of falls on everybody's shoulders. Health problems don't go away just because you don't want to pay for them. So if you ignore them, $1,500 can very quickly turn into $15,000 to $150,000. If you treat, for example, if you treat, it's just much more financially prudent if you look at nothing else. Let's not talk, let's just talk about the financial side of it, to treat illnesses before they become a problem, to do preventative care, to provide vaccines, to provide blood pressure medications, rather than having to treat a communicable disease or treating a heart attack or a stroke. From that perspective, we really need to be focusing on that preventative care. And the way to do that is to build trust within these communities rather than trying to push people away through fear or chaos.
An ounce of prevention, right? Okay, and then I will ask the next question we have from a viewer. This question makes my heart heavy because I feel like we've lost so much. It's about data, and we've already lost like so much data about asylum seekers is already not available to us or has been lost in the sands of time. But the question is, who are the most willing partners for tracking long-term health outcomes for individual migrants? Ganesha, this feels like it might be one for you.
So the data for individuals, like all of us, belongs to those individuals. And so part of the ethics of data and tracking is really about bringing those individuals along that journey. We in our country have not a great track record of public health measures, whether it was, the sham vaccination campaign to when we were trying to capture Osama bin Laden or the Tuskegee syphilis experiments. We don't have a great track record in terms of medical experimentation and data and tracking. And even just using the word tracking, I think, can be really scary for people. So I think the first part, that first partner, the most important partner, is really the individual and making sure that they're along the journey. So in our lab, for example, we do some digital healthcare using sort of cutting edge technology to provide care, early diagnosis and treatment and interventions for our refugee and asylum seeking patients, which is really great. And we love that we're able to do that. But the most important part of that is really making sure that they're okay with the data sharing. They know exactly what we're collecting. They can decide to not participate in that study anytime they want. We can wipe their data. And so that's really important. And then I think also the responsibility, working with responsible, ethical data housing organizations. So in our research, for example, we use REDCap. We get a certificate of confidentiality from the National Institutes of Health that protects the data for those individuals. So I think having both sides of that partnership is really important.
Absolutely, especially when it comes to like individuals' data. So I think that's all we have for questions from the audience, which means that I get to ask some more of my questions. So I'm pretty pleased about that. We only do have a few minutes left though, so I'm going to restrict myself to one. I'm going to ask, I'd love both of you to respond. Maybe we start with Desiree. In terms of solutions, can each of you say, like, what would you like to see from the city government, state government, federal government in terms of aid and policy to help asylum seekers be as healthy as possible and live the best lives possible?
How long you got again? So for fiscal year 2024, Mayor Adams is looking to spend $4.3 billion on migrant services. And it's, as a mutual aid organizer, that number is not tangible to me. It's not something that we organize with so little. My comrades and I have so little and are able to do so much more, I feel, than the city ever could. And I think that it's important for the city to learn from harm reduction organizers, from mutual aid organizers, and really just center peer-to-peer advocacy in the migrant struggle. I think it's really unreasonable to bring in these external contractors at millions and millions of dollars and then have them serve expired food. That has to be unacceptable at some point. We need to make sure that there's a vacancy tax so that we don't have apartments sitting forever unrented, because the housing crisis directly ties into this sheltering crisis. If someone has a 3-year wait in New York City, they're gonna have to live somewhere. And I also think that we need to invest in alternate models of housing, including SROs, so that everyone has an opportunity to live somewhere that is healthy for them and that they can afford, because the housing crisis is really, really severe right now, and it's exacerbated by the climate crisis that we're facing outside.
Great answer. As a physician and a refugee health researcher, I'm always going to advocate for data and science and research. I think what Desiree said is just a perfect complement to all of that, and it's all important together. I think what we have found in our research is that trauma is not fixed, that there is a way to drastically and profoundly alter health trajectories. This is a mostly working age population. If somebody has cardiovascular disease, we don't say, well, that's too bad, good luck, right? We invest in figuring out, how do we treat that disease? What is the best science? What is the best data? What is the best evidence-based care? And we really need to do that with this population. I think it is critically important. We know we can change health trajectories. What happens if we can give pregnant women and children access to vaccines? What happens if we can reduce the stress of migration? What happens to the cardiovascular system? This is not challenging scientific inquiry. This is a very reasonable line of scientific investigation. And the more we know, the more we can actually work to rehabilitate and reintegrate these individuals into our society.
Great, thank you both. I see we have one last question. Do we have time? Or do we need to? Okay, we have time. All right. This is a great question. This is very thought-provoking. The question is, what can big news outlets, WNYC and Gothamist included, do to make this type of information more available to refugee and asylum-seeking communities? I have some thoughts, but I want to bounce it to the experts because I think it's good to have that outside perspective. Ganesha, why don't you start?
Great question. We actually did a study on this about a year ago that we published that shows that having a reliable and consistent source of information is really important to people. So it's one thing, obviously people are getting messages on WhatsApp and Facebook, but if you use a .gov or a .edu website, people trust the information more, but that information needs to be regularly updated and accessible. So you can't have expired information on vaccines. It has to be really active and live and people can access it. And I think news outlets, I think, can really help not just individuals connecting to that information, but also helping healthcare providers, attorneys know what the most up-to-date information is. I mean, we have patients who will say to us, well, my attorney said I can't access this care, or my physician said I can't access such and such public benefit, and those things end up not being true. And I think there is a lot of miscommunication, lack of knowledge, and news outlets, I think, can help resolve some of that, really resolve some of that dissonance.
Great, Desiree?
Yeah, and just to follow up too, I think it's really important that news outlets center migrants in their own reporting and stories, and ensuring that the people that are living this experience have the most feedback in the stories that are being told about them. Because one of the biggest narratives that's being pushed right now is that, it's us versus them, us being people who are born here and them being everyone else. And it's really creating this violent and hateful community in New York City that is even coming to protest migrant shelters in Queens last week, and physically opposing people who are here seeking refuge. So I think that until that is addressed, not only by our politicians, but by the news sources, nothing's really going to change at the cultural level.
A lot for us to think about, and think about how we do this whole news thing. I'm very sad to say that that's all we have time for, but thank you both so much. This was really wonderful. And I'll bounce it back to Sikan.
Great. Thank you, Jacqueline. Thank you to our final panel. So yeah, another day, another annual health convening in the books. I want to thank Caroline, Rosemary, and Jacqueline for moderating the panels today, and to thank all of our guests on each of the sessions and in each of the sessions. I want to also reiterate my gratitude to the Alfred P. Sloan Foundation and the Robert Wood Johnson Foundation for supporting the convening and New York Public Radio. And a huge high five to the Greene Space for hosting the virtual event today, and all the people behind the scenes, producer Veronica Woot Woot, And many thanks to the viewing audience. Hopefully, we won't have another once-in-a-generation health crisis on our hands next year, so we can meet in person to discuss the health topics that touch all of our lives. So thank you again.